Greetings and welcome to our presentation today. I'm delighted to introduce the title of our content, The Echo in Pulmonary Arterial Hypertension. We'll be focusing on the state of the art in right heart monitoring. I'm Dr. Anjali Vaidya. I'm professor of medicine and co-director of the Pulmonary Hypertension, Right Heart Failure, and CTEPH program at Temple University Hospital. And I'm so excited to introduce my colleague, friend, and partner in this endeavor, Dr. John Ryan, who is the director of the Pulmonary Hypertension Center at the University of Utah. Some disclosures for our talk today. This presentation is sponsored by and made on behalf of United Therapeutics. The presenters of this program are compensated by UT. UT neither makes nor implies any specific recommendations regarding patient care or patient management. And this is the United Therapeutics program and is not for CME. Our presentation overview today will cover a few main areas. We're going to start with the pathophysiology of the right heart in pulmonary arterial hypertension. We'll then transition over to the treatment goals in pulmonary arterial hypertension with a focus on imaging and clinical practice. So I'm pleased to introduce again my colleague, Dr. John Ryan.
Thank you, Dr. Vaidya, for that introduction, and thank you to those who are joining us today to learn more about the right heart and the role that it plays in pulmonary arterial hypertension. So the particular focus that I'm going to have is the pathophysiology of the right heart in pulmonary arterial hypertension. We all know that pulmonary arterial hypertension causes increased resistance in the pulmonary vasculature. You go from a healthy endothelium, thin-walled and relaxed pulmonary artery, and a large capillary network that produces a low volume, normal pulmonary vascular resistance, and normal perfusion within the lungs, specifically within the pulmonary arterial system of the lungs. Then, as pulmonary arterial hypertension evolves and progresses, the endothelium becomes abnormal, the walls become constricted and stiff. You actually lose some vessels, so you lose microvasculature, which results in an increase in pulmonary vascular resistance and contributes to a moderate decrease in perfusion in the pulmonary vascular bed. Then again, as the disease progresses further, it is notable that you get further constriction and now accompanied with cell proliferation and an obstructive vasculopathy due to obliterative remodeling that results in severe increases in pulmonary vascular resistance and a severe decrease in perfusion. This is not happening in a vacuum. The changes in the pulmonary vasculature then have effects on the right ventricle and the right heart in general, and ultimately lead to changes in the right heart. Normally, the right ventricle is a thin-walled structure with a normal cardiac output. Although there are changes in the pulmonary vasculature that we've already alluded to, you may not be symptomatic, or you may not be dramatically symptomatic, because for a while at least, you can compensate. Now, how long a while is variable. For some people, it's a couple of months. For some people, it's a couple of years. So it is variable. But ultimately, the right ventricle becomes hypertrophied, and the cardiac output can actually be sustained. When you transition from compensated to decompensated, that largely occurs through changes in the right ventricle, where the right ventricle now becomes dilated, the cardiac output decreases, even the walls might now actually become thinner, and some people would even refer to it as a burnt out right ventricle. In the 2022, the only way to diagnose pulmonary arterial hypertension is by doing a right heart catheterization. That is it. There are no other ways. Other imaging modalities and other tests can give you ideas about prognosis, etc., and we will touch on some of them shortly. And the diagnostic criteria for pulmonary arterial hypertension have actually changed in recent years. One is the pulmonary capillary wedge pressure needs to be low, needs to be less than 15 millimeters of mercury. The reason for that is that if we gave any of us a large volume bolus, our PA pressures would go up. So what we're trying to rule out with the wedge being less than 15 millimeters of mercury is that this is not secondary to volume overload. left-sided heart failure, in essence. The average PA pressure in normal humans, in fact, in every land-living species, the animal kingdom, the average PA pressure, the average mean PA pressure is 14 millimeters of mercury, 1/4. Now we define the upper limit of normal as 20 millimeters of mercury. So when Dr. Vaidya and I were younger, we used to diagnose pulmonary hypertension by having a mean PA pressure of greater than 25. But because, as I mentioned, the normal PA pressure is actually 14, 25 is very far away from 14, so the cutoff got changed. So the cutoff now is a mean PA pressure of greater than 20. Pulmonary vascular resistance has not changed. Normal pulmonary vascular resistance is 1 Wood units. And to diagnose pulmonary arterial hypertension, you need a pulmonary vascular resistance of greater than 3 Wood units. Some argue that that remains too high, but those are the diagnostic criteria once more for pulmonary arterial hypertension. Mean PA pressure greater than 20, pulmonary capillary wedge pressure of less than 15, and pulmonary vascular resistance of greater than 3. After diagnosis, you have someone in your clinic and you know that they have pulmonary arterial hypertension. Well, now, the right ventricle is going to give you important insights into the disease progression. And how your right ventricle progresses and how your right ventricle responds ultimately determines how your disease will progress and how your disease will respond. And here you have, from left to right, you have a normal sized right ventricle with a normal sized left ventricle. Then as the disease progresses, as represented by the arrow, as the disease progresses, even to an untrained eye, you can now see that the right ventricle is getting bigger and is actually bigger than the left ventricle. The right ventricle should never be bigger than the left ventricle. Finally, then, as the disease worsens, you end up in a scenario which to any cardiologist will portend signs of imminent doom. You see that the right ventricle is very big. And actually, perhaps more ominously, the left ventricle is compressed. The right ventricle is compressed in the left ventricle, and it does not take a lot to imagine that your cardiac output is going to be quite low in this setting. Other ominous features on this echocardiogram, we've talked a lot so far about the right ventricle. There's also a great deal to be learned from the right atrium. And in this disease progression slides, you can see that the right atrium goes from being a normal size on the first screen capture to being quite enlarged on the last screen capture. And then, most ominous of all, the echocardiographic finding that is more ominous than any of this is the pericardial effusion. Having fluid outside the heart in the setting of pulmonary arterial hypertension has the worst prognosis of any imaging finding. Now, we've represented this as disease progression, that top arrow. This can also be used to show about improvement with PAH therapies, where you can actually go in the opposite direction, in particular that the right atrium can get smaller, the pericardial effusion can go away with adequate therapy. In this study, which is retrospective analysis of enrolled patients with pulmonary arterial hypertension, 22 patients overall, small study, 12 of whom remained stable during follow-up, and 10 experienced late progression leading to death or lung transplant. In this study, what you can see, the patients who are stable are this gray color with the circles. The patients who progressed are represented by squares. 6-minute walk distance, not much change. Not a big surprise. A lot of criticism over the years about 6-minute walk distance. No change between those who are stable and unstable. New York Heart Association, stayed lower in the stable group, stayed a little bit lower. But the big things that were dramatically different was the right ventricular end diastolic volume, so the size of the right ventricle. And you can see that on the stable population, the right ventricle end diastolic volume remained stable. Whereas in those who got sicker, in those who progressed, as we said, even to death or lung transplantation, the right ventricle end diastolic volume got bigger. And correspondingly with that, the right ventricle ejection fraction, not a commonly used measure, but the right ventricle ejection fraction got worse, decreased, whereas those who remain compensated, the right ventricular ejection fraction remained stable. So this makes a compelling argument that monitoring the right heart can anticipate clinical worsening. Appropriately so, we put a large emphasis on functional class and 6-minute walk distance. But they actually lag in the setting of clinical indicators as to how the disease is progressing. And actually, harmful changes to the right heart can happen weeks, even 12 weeks, before you actually see clinical changes, such as change in 6-minute walk distance or change in functional class. The changes in the right heart are the first thing that will occur, and we don't necessarily have good ways of evaluating that other than echocardiogram. Even these changes in the right heart will precede changes in end-terminal pro-BNP. A lot of us depend on end-terminal pro-BNP in clinic, following patients longitudinally. Then you'll get a change in 6-minute walk, then you'll get a change in weight, then you'll get a change in functional class, and then you'll get hospitalization. So we don't want to progress to change in functional class or change in hospitalization. We want to capture this early. It is very hard when someone changes their functional class, it is very hard to get them back to their previous functional class. When someone has been hospitalized, it gets even harder. So performing a routine echo may help catch patients whose pulmonary arterial hypertension is progressing before the symptoms are evident, arguably even before the BNP. Managing by symptoms alone may be a detriment to patients. In a retrospective analysis of functional class 2 patients, more than half were classified as intermediate or high risk after risk calculation. In this study, retrospective chart analysis of 153 functional class 2 patients on 1 or 2 drugs, and the healthcare providers were surveyed to obtain an assessment of patient risk, which may have been informed by formal assessment. Patient risk was then calculated independently using Compara, French Registry, or Reveal 2.0. Of patients considered to be low risk by Gestalt, so the regular old reliable, I look at you, I determine you to be low risk. Of those patients who were considered to be low risk by Gestalt, 4 to 28% of them were characterized as high risk when objective measures were used. All of this reflects that if we wait for symptoms to worsen before adjusting our patient's treatment regimen, the opportunity to minimize functional impairment may be lost. We've emphasized this functional impairment. Now let's talk about the actual treatment goals, which are functional improvement. Patients who achieve low risk status within 1 year of diagnosis have improved survival. We can see this from the graph on the right, which is the impact on survival per change in risk category in the Compara registry. Within the Compara registry, patients were assessed with an abbreviated version of 6 risk factors from the ESC and ERS guidelines. These risk variables were WHO functional class, which we've talked about a lot so far, 6-minute walk distance, end-terminal pro-BNP and BNP, right atrial pressure, cardiac index, and SpO2. Survival then was estimated based on risk category. As you can see in this graph on the right, stable, low-risk patients are represented by the dark green. And as you can see, at 1 year, if you are stable, low risk, by 5 years, your survival is between 80 and 90%. This is higher than the stable intermediate risk, which is the dotted light orange line, where you can see that, again, if you get to stable intermediate risk at 1 year, your survival is about 60, somewhere between 50 and 60% at 5 years. The worst prognosis then in this data from the Compara registry is the stable high risk, represented by the solid red line. Therefore, treatment should be escalated if patients do not achieve low risk status. In conjunction with the low risk, what we also want is near normalization of right heart function. This is another important treatment goal. We have seen over and over and over on the slides today that the right heart, as I say, is the key to the whole game. And if we get near normalization of the right heart, then we are in a really good spot to give the patients the best possible outcomes that they can have. Acknowledging, of course, that we do not have a cure for this disease, but at least we can let patients know that you are as low risk as possible. So what is that, and how does that pertain to the right ventricle? Well, this, based on the European Society of Cardiology and the European Respiratory Society risk score, N-terminal pro-BNP, you want that to be less than 300, you want BNP to be less than 50. We measure those every time we see a patient in clinic. Clinical signs of right heart failure, you do not want to see them. You have to look for them, but you don't want to see them. What's that? Increased JVP, enlarged liver, lower extremity edema. Syncope is a sign of right heart failure. If patients are having syncopal episodes, then that is a high risk characteristic. If patients are not, you're happy out and they are low risk. Now, the next does require invasive hemodynamics. Low right atrial pressure, normal cardiac index, and SpO2 of greater than 65%. All of these reflect good prognostic indicators, and all of these are reflective of the right ventricle. Then with imaging, we want to see a right atrial area that is small. And as I mentioned earlier, we do not want to see a pericardial effusion. Improvement of the right heart is one of the most important considerations to get people to low risk status and improving survival. Treatment guidelines recommend serial echocardiograms for routine surveillance. You get them at baseline. You likely should get it 3 to 6 months after changing or starting therapy. You should get it in the case of clinical worsening. And then there are many who do it even in stable patients every 6 months. The importance of frequent echo is shown in this retrospective study. This was a chart analysis of 150 functional class 2 patients who were on 1 or 2 medicines for their pulmonary arterial hypertension. And the healthcare providers were surveyed to obtain an assessment of patient risk, which had been informed by formal risk calculators. The patient's risk was calculated then using Compara, the French registry, and Reveal 2.0. So the congruence of Gestalt and formal risk assessment based on this echo frequency was that in those who got echocardiograms every 3 months, 82% of those patients were congruent with the risk calculation that was used. 18% were not. In those whose echocardiograms were obtained every 7 to 12 months, 46% were congruent with the risk calculations, whereas 54% were not. So the take-home point from this study is that physicians who ordered echoes more frequently every 3 months were more likely to accurately assess their patient's risk status. The echo evaluations help stratify patients. Intermediate risk is a vast category of patients. Here's one patient, 42 years of age, functional class 3A, 6-minute walk distance 405, BMI 21, and hemoglobin is 14. So some normal aspects here, some intermediate risk aspects. Ultimately comes down to being an intermediate risk patient. This patient here, 45-year-old female, functional class 3A, 6-minute walk distance is the same at 410. BMI is 20 and hemoglobin is 13. So again, a couple of intermediate risk aspects there. Both right ventricles are enlarged. One on the right, patient 2 has pericardial effusion and has that left ventricle being compressed. So the echo may assist with determining the treatment regimen needed to help a patient achieve a low risk status. Because in hindsight, looking at these echoes, although both patients fell into an intermediate risk category, looking at these echoes, in particular the one on the right, these patients are high risk of complications. And we want to get patients to low risk. So at this point, I want to bring in Dr. Vaidya to cover some of these aspects and cover how to implement these aspects in clinical care. So, Dr. Vaidya, I touched on the issues of echocardiogram incorporating into your treatment algorithm, diagnostic algorithm, etc. how often are you doing your echocardiograms?
Thanks, John. I think that's a great question, and I'm asked this quite a lot actually when I speak to folks. So I'm going to be really interested to hear about your program's practice also. I really want to emphasize some of the data that you so nicely presented about how, if we do our echoes more frequently, then our clinical gestalt tends to be more in line with a formal, validated, objective risk assessment. And I think that point is really key. So I always tell my fellows and my residents, the echo doesn't lie. Whereas, you just nicely presented a case where 6-minute walk in functional class could represent such a wide range of actual cardiac performance. So it's a long-winded way of saying more frequent is better. For me, if a patient has WHO group 1 pulmonary arterial hypertension, and there's any change in their clinical status, there's change in their functional capacity, there's change in their physical exam, their jugular venous pressure is up, they're retaining fluid, they're having presyncope, their BNP or NT-pro starts to rise, then I'm immediately getting an echocardiogram, at that clinical assessment, regardless of when the last one was, because we know you so nicely presented in the beginning how this is a progressive disease, and you showed that pathophysiology. And it's amazing, right? How some patients it can happen slowly and gradually, and some patients can seemingly have no progression, and then it can suddenly happen quickly. So any sign of a clinical change and a relatively urgent echo, if I'm escalating therapy or if I've recently changed their therapy, then I'm not waiting more than 3 months for my next echocardiogram. And then I would say in the ideal, what we all strive for our patients, the patients that have had truly low risk status that has maintained for quite a long period of time, and we're objectively looking at all of those parameters, then I may stretch it out to 6 months. In my opinion, 12 months is far too long. This is a progressive disease that cannot wait that long for such a careful, objective assessment. So that's kind of my take on it. How do you approach it?
We're exactly the same, but we'll emphasize the 6-month issue that you bring up. Yes, so we also do it every 6 months. Similarly, then, as you said, when you're up escalating therapy, then again, that's where you want to see that response. That patient you're seeing more frequently, and you want to see a response. You want to incorporate that along with everything else that you're seeing to show that I have done the right thing. You always feel you've done the right thing for the most part, but that I am actually seeing a response. And I can rest on my laurels here because 12 weeks after changing therapy, I've got them down to low risk. I've got their echo looking better. But one of the things that I emphasize with our fellows is that the right ventricle can fool you. You and I measure TAPSE all the time, but TAPSE can fool you. We don't touch on TAPSE here, but TAPSE, just to clarify, is movement of the tricuspid annulus with each compression, with the idea being, or each contraction rather, with the idea being that the more that your right ventricle moves, the better it is. That can fool you. That can trick you, and you've done a lot of the work on TAPSE. Right ventricular size can fool you. If the right ventricle gets dilated, it stays dilated. The right atrium is very adaptive, and I feel that the right atrium is my favorite chamber. We have lots of chambers to choose from, Dr. Vaidya. The right atrium is my favorite chamber because the right atrium will get bigger as you get sicker and will get smaller as you get better. And getting echo techs in any lab, this is not a criticism, this is not ivory tower or elitism, but getting echo techs to look at the right ventricle can be challenging because we are so LV centric. Getting echo techs to look at the right atrium can be even more challenging. But that is ultimately where I think the truth lies, is what is the right atrium doing?
That's interesting. I like to look at that as well. And certainly right atrial area at atrial diastole has been shown to correlate with mortality in PAH. And I think what you're describing reminds me of, I think, an easy to remember concept, which is I'll often say, any parameter that represents performance of the right side of the heart has likely been studied in, and more importantly, shown to correlate with outcomes in pulmonary arterial hypertension. I'm very grateful that in the years that we've been in this career and taking care of PAH, that the attention to the right heart has really exploded in a favorable way, finally in the right direction, although it's taken some time. But I think it's important to note that the assessment on echo really is an integration of multiple parameters, like you're alluding to, the congestion on the right side of the heart, which can be shown in that IVC, the degree of tricuspid regurgitation we haven't alluded to yet, but is a representation of that as well. I really like that you mentioned about the right heart, not necessarily the right ventricle, not necessarily changing or reversing. And I've struggled with that. And I think what I've come to appreciate is that there are some patients, and I think chronicity plays a big role in this. There are some patients where their right ventricular size and shape and function might reverse with therapy. And that is the most satisfying thing, I think, for us when we're taking care of patients. But there are other patients who have the same looking or similar looking initial echo features that you described, with that enlarged right ventricle, dysfunctional right ventricle, the shape might be abnormal. And on treatment, they feel better and their BNP falls and they walk further. And you look at their echocardiogram, and part of your brain is saying that right ventricle still looks really abnormal, right? And you can kind of wonder what do we do with this? And what I've come to appreciate is the distinction between RV size and RV function. And I think it's a really real phenomenon. And this is where patients that have had very chronic remodeling and chronic severe disease, sometimes that right ventricle may not fall in size or shape. It may not reverse as much as we'd like to see, but the function absolutely can. But it takes a really discerning eye to make that distinction. And I don't think you said this yet, but your expertise alludes to this, that there's a lot of value when risk assessing these patients to look at those pictures yourself. Do you have a similar experience in your practice? Because I love that you said, the echo kind of trumps everything else. I want to know what that echo looks like. So does that mean you're looking at the pictures in your practice, in your clinic, or just going by the reports in the risk assessment?
The feature of the exam that I said that I don't care about can actually be replicated in echo as well. We had a patient recently, one of our patients, myelofibrosis with pulmonary arterial hypertension and steady myelofibrosis. She came in exertional dyspnea. She came into one of the urgent care, like the oncology acute care, which is essentially the same as the ER. They got an echo. One of our faculty, is not a criticism of one of our faculty, but it's just instructive as to how you can just hang your hat too much on one thing. One of our faculty read the echo. Right ventricle was big, right atrium was big, pulmonary artery was big. The tricuspid, the estimated RVSP came out at 25. Word got back both to me as well as to the acute care saying, not pulmonary hypertension, don't worry about it, must be something else. I pulled up the echo. True enough, right atrium was big, right ventricle was big, pulmonary artery was big. I didn't care what the tricuspid regurgitation was. I didn't care what the estimated right ventricular systolic pressure was, because none of this is happening in a vacuum, and everything is about the company it keeps. What is the company it keeps? And in that setting, we took her to the lab. Sure enough, estimated RVSP was 45, got her an extra therapy. So with that in mind, we've talked a lot about the right ventricle. For most people who don't do this for a living, right ventricular assessment is RVSP, right ventricular systolic pressure, tricuspid regurgitant jet. And I guess the question I have for you is, what role do the pressures play? What role does RVSP play in your assessment of right heart function or pulmonary hypertension in general on echo?
That's great. I'm so glad you brought that up. And I think that's a perfect point to end on for this discussion. So there is so much variability and error in the RVSP estimation for a variety of echo Doppler kind of technique issues. And this has been shown time and time again, particularly some data that show, up to 50% of patients will have a 10 millimeter of mercury error in the echo Doppler estimation of pressure relative to the directly measured hemodynamics. So the bottom line is the pressure is never the answer. It's never the answer in the diagnosis. It's never the answer in the risk assessment, even less so. It's meant to raise awareness to look closer. And once you have a suspicion of it, we have to look at all of the right heart parameters: right ventricular size, structure, function, tricuspid regurgitation, right atrial size and shape, IVC, collapse, and all of those things. And so I've really enjoyed this discussion with you, Dr. Ryan. Thank you so much.